Okay, I think we can start now. Good evening, everyone, and welcome to another session of Young Family Physicians Forum. I welcome Madam Lalant Senaratne, Consultant Family Physician, and all the registrars for this session. Today, our speaker will be Dr. Nimasha Silva from the Junior Most batch, and I invite Dr. Gayani Minuampitia of the same batch to give her introduction. Over to you, Gayani.
Thank you. Dr. W. Nimasha Silva is a graduate of Faculty of Medicine, University of Colombo, and has many years of experience as a medical officer of anesthesia and intensive care. She obtained her postgraduate diploma in family medicine in 2021 and is currently a first year registrar in MD Family Medicine. Over to you, Nimasha.
Thank you, Granny, for that kind introduction. Good evening, everyone. Today, my topic is to talk about the challenges in managing poorly controlled hypertension in primary care. So, as we all know, it is a very common presentation to us in primary care. On daily basis, we encounter patients who are on antihypertensive drugs, yet their blood pressures are not controlled up to the target values. So it's a sort of a very common presentation. And today I'm going to discuss about a patient that I met at the Divisional Hospital Sadalankawa while I was doing the family medicine appointment. Based on her history and her story, we will make this discussion. My patient was a 50-year-old lady, followed up for hypertension for the last 6 years in the clinic. And she was diagnosed with hypertension at a routine medical checkup. And also she was diagnosed to have dyslipidemia 2 years back and was started on treatment. So in her past medical history, other than hypertension and dyslipidemia, she did not have any other medical issues. Surgical history is also not significant. In the menstrual history, she had regular periods and she was on oral contraceptive pills. And she was a mother of 2 children, 2 school-going children and a housewife, and she had a good family support. So in this, as I mentioned, this was a routine clinic visit, and in this visit, she did not have any new complaints to add. So during the examination, her BMI was 23.1. She was not pale, no ankle edema. In the cardiovascular system, blood pressure was 180 over 100, and no murmurs, and the lungs were normal. So with this blood pressure, I went back to her notes to see how her blood pressure was controlled during the past clinic visits. To see her blood pressures was almost to the high side. I have given the values, and it was into the high side. And her investigations revealed that the fasting blood sugar was normal, and the total cholesterol 189 with the LDL of 88, creatinine was normal, and electrolytes were normal. In the ECG, there was mild LVH, and ultrasound scan had also been done due to this uncontrolled sort of hypertension, and that was also normal. So currently, she was on losartan 50 milligrams BD, and hydrochlorothiazides 25 milligrams MANE, and amlodipine 10 milligrams BD dose, and processin 1 milligram BD, and atorvastatin 20 milligram Nocte. And due to this uncontrolled sort of hypertension, in the clinic, they have planned a cardiology referral, and she has taken a date from Kurunagala, and she was awaiting that cardiology visit. So, in summary, she is a 50-year-old lady diagnosed with hypertension for 6 years and dyslipidemia for 2 years on a routine clinic follow-up on 4 antihypertensive drugs with poor control of blood pressure, awaiting a cardiology referral. So, with that being said, I will give you a few seconds to think about this patient. If that patient comes to you, what will be your thoughts? How are you going to set up a plan of management? Well, these were few things that I thought of. Whether is this blood pressure reading is correct in order, like whether the method of measuring and the instruments, are they correct? And does she needs urgent referral? And what about her compliance? Has she taken the morning antihypertensive pills, and is she compliant with her medication? And is there any secondary cause, any other thing that is adding on to this high blood pressure readings? So these were few of my thoughts. So being said, as we all know, hypertension is classified in many ways, and there are gradings. And this is the national guideline grading system. And here you all can see the normal blood pressure is they have taken systolic less than 130 and diastolic less than 85. And the high normal is systolic 130 to 139. And the grade 1, grade 2, again, the grade 2, they have taken more than 160 systolic blood pressure. And the newer, this is the ESC guide, European Heart Journal Guideline 2024. Here they have, you all can appreciate the fact that they have come down in the cutoff values, and the normal is they have taken as 120, and they have added elevated blood pressure categories, that is systolic blood pressure 120 to 129 and diastolic less than 80. So, and also the stage 1, stage 2 also, stage 2 has come down to 140 systolic and 90 diastolic. So here we can appreciate the fact that they have come down in the cutoff values, meaning that we need to be more cautious about this levels and targets of our blood pressure control. So there are many definitions when it comes to hypertension, and you all are familiar with this: the hypertensive emergency, hypertensive urgency, resistant hypertension, refractory hypertension, pseudo-resistant hypertension. So in the next few slides, I will just go through these classifications to clear out things so that we can safely grade our patients in order to manage them accurately. So classification of hypertension could usefully be done under 3 main headings. That is the etiology, the response to the therapy, and the duration of hypertension. So this is the more familiar thing to us. The classification based on etiology is useful in investigation of the hypertensive patient. So that is primary hypertension and secondary hypertension. Response-based classification is useful in selecting drugs for control of hypertension. So that is the hypertensive emergency, hypertensive urgency, resistant hypertension, refractory hypertension, and pseudo-resistant hypertension can be categorized under that. And when it comes to the duration, temporary forms of hypertension must be recognized so that unnecessary treatment can be prevented. So stress-induced hypertension, drugs or chemical-induced hypertension, and transient gestational hypertension are a few of the examples. And then you all are familiar with these two terms, the hypertensive urgency and hypertensive emergency. So if the blood pressure, the systolic blood pressure is more than 180 and diastolic more than 110 with no evidence of end organ damage, it is categorized under hypertensive urgency, whereas if the blood pressures are more than 180 and 110 with the evidence of organ damage, then it is categorized as hypertensive emergency. So the pulmonary edema, cardiac ischemia, neurological deficits, and acute renal failure are the evidence. And how can the patients present is like they can present as they can have headaches, visual disturbances, chest pain, shortness of breath, dizziness, and even some will have neurological deficits. And hypertensive encephalopathy is also another entity where a patient might have somnolence, lethargy, and even tonic-clonic convulsions. And then the term resistant hypertension. So hypertension is defined as resistant when blood pressure that remains above the goal in spite of concurrent use of 3 antihypertensive agents of different classes. And also the treatment strategy, including appropriate lifestyle measures, and the treatment with maximum or maximally tolerated doses. So the 3 classes that is included is a diuretic, thiazide or thiazide-like diuretic, and then angiotensin receptor blocker or angiotensin AC inhibitor, and a calcium channel blocker. And with that, if they fail to lower the office systolic and diastolic blood pressure values to less than 140 and 90 respectively, then it is categorized as resistant hypertension. And then the term refractory hypertension, some patients with resistant hypertension cannot be controlled even with maximal medical therapy, that is 5 or more drugs, including a mineralocorticoid receptor antagonist. So those patients are categorized under refractory hypertension, and they have to be under the care of hypertension specialists. So the term pseudo-resistant hypertension, this is where poorly controlled hypertension that appears resistant to treatment but is actually attributable to other factors. So now the challenge for us at primary care level is to identify whether the patient is having true resistant hypertension or whether this is a pseudo-resistant hypertension where some other contributory factor is there that is keeping the blood pressure high. So in general, when we manage hypertension patients with hypertension, we have noticed that some patients are anyway difficult to control. They are sort of difficult customers. Usually systolic blood pressures are difficult to control than diastolic, and patients with left ventricular hypertrophy, old age, obesity, CKD, and patients with diabetes, sometimes the blood pressure control be anyway difficult. And with more combinations, the more difficult it is to control the blood pressure. But when it comes to resistant hypertension is not a disease per se, and
Nimasha, don't move the slides too often, right?
Madam, I'm not moving, it's just...
What's going on here?
Okay, I think now it's
Because
okay.
it's nice, you have a nice flow, but anyway, the thing is, this is moving and it's disturbing.
I think it's okay now, madam. Sorry, madam. Right. So, so the resistant hypertension is not a disease per se, compared with treated patients who achieve their blood pressure control. Patients with resistant hypertension, by any definition, would have a worse prognosis. So the risk of myocardial infarctions, strokes, end-stage renal disease, and death in these adults are maybe 2 to 6-fold higher than the controlled population. And also the secondary cause of hypertension are also more likely in the presence of resistant hypertension. So pseudo-resistant hypertension is where there is some other cause contributing to this high blood pressure. And the 5 most common causes for pseudo-resistant hypertension are inaccurate measurement of blood pressure, poor adherence to antihypertensive therapy, suboptimal antihypertensive therapy, poor adherence to lifestyle and dietary approaches to lower the blood pressure, and white coat hypertension. So some other factors are excess alcohol intake, overweight, obesity, and physical inactivity, excess daily sodium intake, and obstructive sleep apnea, and some drugs. And also, the common causes of secondary hypertension can also be contributed to this resistant hypertension, the list that we all are familiar with: the primary hyperaldosteronism, renal artery stenosis, chronic kidney disease, obstructive sleep apnea, hyperthyroidism, pheochromocytoma, and Cushing's syndrome. In renal artery stenosis, it is more common when it comes to young hypertensive patients. We consider that the renal artery stenosis is a differential diagnosis, but not only in younger patients, with the process of atherosclerosis, the plaque formation, even with aging, you can get renal artery stenosis. So with time, it can develop and can cause this resistant sort of difficult blood pressure control. So those things are also contributing. So when it comes to medication, a variety of medications can raise the blood pressure and in some cases reduce the response to antihypertensive drugs. So the most common implicated agents are the over-the-counter and prescribed medications like non-steroidal anti-inflammatory drugs. But not all. One example is celecoxib. And the NSAIDs are that raise blood pressure can interfere with the antihypertensive effect of virtually any agent except calcium channel blockers. And the mechanism by which the blood pressure rises is the reduction in sodium excretion, thereby increasing the intravascular volume. Other drugs that is contributing to high blood pressure are sympathomimetics like diet pills, decongestants, amphetamine-like stimulants, corticosteroids, some herbal preparations, estrogen-containing contraceptives, and antidepressants. So a few words about white coat hypertension. White coat hypertension is the detection of elevated clinic blood pressure in untreated individuals in the presence of normal ambulatory blood pressure monitoring or home blood pressure monitoring. So studies reveal that about 10 to 30% of people attending to clinics have white coat hypertension, and it is commoner in grade 1 hypertension and also in very old people. So it should be suspected when the clinic blood pressure is more than 140/90 on more than 3 separate occasions and in the absence of hypertension-mediated organ damage. So ambulatory blood pressure monitoring or home blood pressure monitoring should be performed in suspected individuals, and average 24-hour ambulatory blood pressure monitoring less than 130/80 and home blood pressure less than 135/85 confirms the diagnosis. And assessment should be done to identify the cardiovascular risk factors and the hypertension-mediated organ damage. So with that being said, now for my patients, my challenge is to see why her blood pressure is not controlled with these 4 medications. So to sort it out, I went back to the history to see whether I can find anything that has been missing. So she was diagnosed with hypertension for six years back, and she was asymptomatic at the time of diagnosis. And it was controlled initially, and it was during the last 2 years that she had the trouble in controlling her blood pressure. And according to her, the compliance was good. In her history, there is no suggestive history of angina or ischemic type of chest pain, no exertional dyspnea, paroxysmal nocturnal dyspnea or orthopnea or edema, no history suggestive of any peripheral vascular disease, no intermittent claudication, no breast pain or ulcers, no history suggestive of a stroke, TIA or blurring of vision or changes in the level of consciousness. And there were no excuse me. Can you see my slides?
No, slides are gone.
What had happened?
I don't know. 1 minute.
Who is doing this? I mean, you are the person who is moving the slides, or somebody is doing. You are just
I'm moving, madam. 1 minute, madam.
Okay. Are there any year 3 registrars other than Indralas? Because from the college, I mean, like the one who is with the logo. Who is the one with the logo then?
I'm Prabhat, madam.
Prabhat, what's going on there?
Now she can share it, madam.
Okay.
Right. You can see the slides, right?
Yeah, visible.
Okay, right. Okay, so in the history, there was no anorexia, nausea, vomiting, hiccups, or symptoms suggestive of anemia. No recurrent urinary tract infections, renal calculi, childhood urinary tract symptoms like hematuria or recurrent infections. No episodic headaches, palpitations, sweatings, and there was no symptoms suggestive of proximal muscle wasting. She was clinically euthyroid with without any menstrual irregularities, no recent changes in her weight, bowel habits were normal, and no cold or heat intolerance. So the only thing that I found is that the fact that she was on oral contraceptive pills for the last 15 years. I would not say this can be the only cause for her uncontrolled hypertension, because there are many factors around her. Even when it comes to compliance is to drugs is also not an easy thing, because hypertension is not a symptomatic thing, and when you're on drugs for a long time, consistency is not a easy thing, as we all know. So there can be ups and downs in compliance as well, but this is the only thing that I found. So from here, my presentation, I will talk a little bit more about the contraceptive pill and the relation to in relation to hypertension. So other than that, during the examination, I have to make sure that my blood pressure monitoring and the devices are accurate. And this is something that you all are familiar with, the correct method of measuring blood pressure. So it has to be a quiet room, comfortable temperature, no smoking, coffee, exercise for 30 minutes, empty bladder, relax for 3 to 5 minutes, and you have to take 2 measurements at 1 minute intervals. And if there are any substantial difference between 2 readings, you have to take a third measurement as well and use the average of the last 2 measurements. And the position is also, you have to be in a comfortable seat, back supported, and you should not talk during during the measurements, and the cuff should fit the arm size, and arm has to be resting mid-arm at the heart level. So, and we checked her blood pressure manually and with 2 apparatus. So there were nothing significant different. There was no difference in the measurements. So I went back to the physical examination as well. It helps to determine the extent and the complications of the hypertension. So fundoscopy, retinopathy, to detect retinopathy and murmurs, and then bruits, carotid, and in the abdomen you can look for renal bruit and also varied arm and lower extremity pressure. So those were also negative in my patient. And this is not the exact ECG of my patient, but something similar. So as you all know, there are many criteria to diagnose left ventricular hypertrophy. And the one criteria is that the S wave depth in V1 and the tallest R wave height in V5 or V6 more than 35 millimeters. So that was the only finding. So the only positive thing that I found was the hormonal contraceptive pill. So in the next few slides, I will quickly go through about these contraceptive methods. So the combined oral contraceptive pill has been a popular choice of contraception since it was first introduced in 1961. The combined oral pill is a combination of low-dose estrogen and progesterone, traditionally taken for 21 days, followed by a 7-day break. And it works by preventing ovulation, thickening the cervical mucosa, and thinning the endometrium. And according to the estrogen dose, the type of progesterone, they are classified into 4 generations. So as you can see, there are 4 generations, and when it come down to the 4th generation, the dose of estrogen has reduced. Where in the first generation, the high dose estrogen 150 with noestrone is there, but when it comes to the second and third, the estrogen dose is reducing. So these are few commercially available preparations. The Mithuri contraceptive pill, where 30 micrograms of ethyl estradiol and the 150 micrograms of levonorgestrel is there. So the Yasmin and the DAME 35 are the commercially available preparations for us to use. So the risks of combined oral contraceptive pill is that we are familiar, the venous thromboembolism, ischemic strokes, breast and cervical cancer, and the mood changes are few. And the benefits, it improve acne, decrease the menstrual pain and bleeding, decrease symptoms of perimenopausal symptoms, and decrease in menopausal symptoms, and also the decreased risk of ovarian, bowel, and endometrial cancer, and etc. With that being said, when it comes to contraindications to use oral contraceptive pills under medical eligibility criteria for, there are many contraindications, and as you all can see under that, uncontrolled hypertension is one contraindication. So if the patient is not controlled with medication, we have to be cautious when we are using oral contraceptive pill. And also under relative contraindications, even controlled hypertension is there, they are under a relative contraindication. And there are a few reasons to stop combined oral contraceptive pills immediately. So sudden breathlessness, unexplained swellings, or severe pain in the calf, acute abdominal pain, serious neurological effects like long headaches or sudden dysphagia, partial or complete vision loss, like that. There are many reasons to stop combined hormonal contraception immediately. And with that, blood pressure more than 160/95 is a reason to stop the combined oral contraceptive pill. So there are many research that have been conducted to see this relationship between the contraceptive pill and hypertension. Studies recording longer cumulative OCP use have continued to demonstrate significant association between the duration of use and hypertension risk. And in a case control study from China that reported more than 20 years of OCP use, every additional 5 years of use was associated with higher odds of hypertension. And this is a recently done a systematic review with statistical comparison between the randomized control trials to see the association between the use of oral contraceptives and the occurrence of systemic hypertension. And conclusion is that the results suggest that individuals with hypertension should exercise caution with ethyl estradiol, particularly when administered cyclically alongside with progesterones, due to the potential risk of increased blood pressure. So in conclusion, when it comes to combined oral contraceptive pills, it is safe for healthy non-smoking women until the age of 50 years. But it is not recommended if a woman is over 35 and has cardiovascular risk factors, including obesity, smoking, diabetes, and hypertension. So in that case, the contraception in women over the age of 40 is discussed in sort of a separate entity, and there are these are the methods that are available for women over 40 years because of these multiple medical problems, and why they have we talk about contraception in women over 40 is that women over the age of 40 years have unique set of factors to consider when discussing contraception. And though there is a natural decline in fertility with increasing age, contraception is still necessary to prevent pregnancy until menopause. So in women over 40, there are different risks related to pregnancy, background health concerns, and evolving risks and benefits of each contraceptive method to consider. And therefore, it is important to be knowledgeable on how to assess the needs and the priorities and the patient wishes when it comes to select a contraceptive method. And also, they are at the women over the age of 40 are at a risk, increasing risk of cardiovascular disease and venous thromboembolism. And these are conditions that can also be affected by the use of contraceptive methods. And additionally, although the risk of cervical cancer decreases with age, endometrial, ovarian, and breast cancer risk is increasing. And women in this cohort are also at greater risk of osteoporotic bone fractures due to the decreasing bone mineral density due to the reducing levels of estrogen. So these factors, along with the onset and the impact of perimenopausal symptoms, these group of women need separate guidance in order to select the correct contraception method. So if not the oral contraceptive pill, what are the other methods that are available? So progesterone-only contraception is another possible available method. And there are, again, reasons to avoid progesterone-only contraception, that is concurrent breast cancers, trophoblastic disease, liver disease, if new symptoms or diagnosis of ischemic heart disease or stroke or migraine with aura is occurring when taking the progesterone-only contraception. And also you have to investigate any undiagnosed vaginal bleeding before we are starting on progesterone-only contraception. So one available thing is the progesterone-only pill. So oral progesterone-only pill is suitable alternative for women for whom combined oral contraceptive pills are contraindicated. So we can use it for women aged more than 50, up to the age of 55. And even smokers can use it. And women with past history or predisposition to venous thromboembolism can use it. And patients with increased blood pressure, valvular heart disease, diabetes, migraine with aura, this is one possible option. Then again, there are side effects. It has a higher failure rate than the combined oral contraceptive pill. There are menstrual irregularities like oligomenorrhea, menorrhagia, and amenorrhea. There is increased risk of ectopic pregnancies and other side effects like nausea, vomiting, headaches, dizziness, breast discomfort, depression, skin disorders, and weight changes, reduced libido are there. And long-term use, there's a small increased risk of breast cancer. One major disadvantage is that it is the compliance matters when it comes to the progesterone-only pill. So you have to take it every day at the same time. If it is delayed more than 3 hours, it is treated as a missed pill. So you need to find an emergency contraception method if you delay the tablet for 3 hours, which is a drawback in progesterone-only pill. So there are injectable progesterones, which is more popular in certain group of women. So it is useful if estrogen-containing preparations are contraindicated or for ones with poor compliance, can be used to age 50 if there is no risk of osteoporosis, and it decreases the ectopic pregnancy, functional ovarian cyst, and sickle cell crisis, and it reduces the risk of endometrial cancer. Also may elevate the premenopausal syndromes and decrease menorrhagia. The disadvantages in injectable progesterones is that it's relatively the relative contraindication if the patient is having diabetes with complications. And may decrease bone mineral density in first 2 to 3 years of use. And we have to consider DEXA scan in older women if result would influence the choice. And maybe a delay, there may be a delay in returning into fertility up to 1 year on stopping. And there can be menstrual disturbances, and weight gain and mood swings, acne are some other side effects. So the other option is progesterone implants. Again, it lasts for 3 years, and once inserted, the compliance is not a matter. It can be used for women at risk of ectopic pregnancy, and there is no effect on bone density, and once removed, fertility returns to normal. So the disadvantages are that specialized training is needed to insert and to remove the implant, and complications of a minor surgery can occur, and it decreases the efficacy with liver enzyme inducing drugs, cannot be used as a part of HRT regime, and may cause menstrual disturbances and other common side effects like acne, mood swings, and breast tenderness and changes in libido are there. So finally, the intrauterine contraceptive devices, as you all know, there are two types, those containing progesterone and those containing copper. So the intrauterine system, the levonorgestrel releasing intrauterine system, release progesterone directly into the uterine cavity and act by preventing endometrial proliferation, thickening of cervical mucus, and suppression of ovulation. And they are licensed for use in women aged more than 18 years for contraception, for treatment for menorrhagia, and also to prevention of endometrial hyperplasia with estrogen therapy. So the advantages are that it reduces the risk of pelvic inflammatory disease, it reduces the risk of ectopic pregnancies when compared to the copper IUCD, and also if they are more than 45 years and amenorrheic, it can be left in situ for 7 years for contraception until they reach menopause. So the copper intrauterine device, again, act by inhibiting fertilization, sperm penetration of the cervical mucus, and implantation. And it is suitable for older Paris women, fitted in for women more than 40 years, and may remain in the uterus until after menopause. And also as a second-line contraception for young nulliparous women, and also there's a place for emergency contraception as well. So in contraindications, mainly for copper IUCD, the allergy to copper, Wilson disease, and heavy or painful periods are contraindications. And to both intrauterine devices, pregnancy and less than 4 weeks of postpartum is a contraindication, and current or high risk of STI or pelvic inflammatory diseases will not fit into this. And also following treatment of sexually transmitted diseases, the suitability depends on the ongoing risk, and undiagnosed uterine bleeding and distorted uterine cavity, endometrial, ovarian, or cervical cancer. And also if the patient is on anticoagulation, then again have to be cautious. So the advantages of this intrauterine device is that no systemic side effects, and does not mask the symptoms of menopause. If fitted as emergency contraception, it can provide ongoing contraception as well. And for women more than 40 years, it can remain in the uterus until menopause. So long-lasting and can be used until menopause. Once fitted, no compliance is needed, and it is easily or immediately reversible by removing. So it can be used for women who are breastfeeding, obese, and have concurrent illness like migraine, venous thromboembolism, diabetes, cardiovascular disease, and for those who are taking long-term enzyme-inducing drugs. Having said all that, now does my patient need a contraception method? She is 50 years old, on oral contraceptive for 15 years and having regular periods. So that was my question. So contraception and menopause, these were the recommendations. Advise who are not using a hormonal method of contraception to continue using contraception after their LMP for 1 year if aged less than 50 years, or 2 years if aged less than 50 years. So where timing of menopause is unclear due to the use of contraception, like in my patient, or if they are on HRT, the advice the women to continue contraception until the age of 55 and then stop. So, and HRT is not a contraceptive unless intrauterine system is being used as progesterone component in the HRT. So, when it comes to my patient, the hypertension part, although she was on 4 drugs, they have already done some modifications and see that whether the blood pressure is controlling, but still there is a chance to increase the thiazide diuretic dose. And the recommendations are to the reinforcement of lifestyle measures, in particularly the salts restriction. And the pharmacological management is addition of low-dose spironolactone for the existing treatment. And if intolerant to spironolactone, additional of further diuretic therapy with amiloride or higher dose of thiazide or thiazide-like diuretic can be added, or a loop diuretic like furosemide if the GFR is less than 30. And addition of beta blockers like bisoprolol or metoprolol or sustained release alpha blocker should also be considered, and then to refer to a specialist if the blood pressure is not controlled. So after discussing with the family physician, this is what we thought the best for our patient. So we advised her to stop the oral contraceptive pill and advised her to use a barrier contraceptive method until the menopause is confirmed. And we were thinking of adding a spironolactone. Then again, because we are now stopping the oral contraceptive, and if it has contributed to her high blood pressure, we thought that we will monitor her up for 1 month and to see whether her blood pressure is coming down with stopping oral contraceptive, and then to do accordingly. And anyway, her follow-up, her referral for the cardiology referral has already been arranged. So we were planning to review her in 1 month. So that brings to the end of my presentation, and these were my references. And also I would like to thank Madam Lalanta Senaratne for her continuous guidance, and with her busy schedule for allocating time to help us to improve ourselves. Thank you very much, Madam, and thank you for listening.
So you may ask some questions.
Thank you, Dr. Nimasha, for that elaborate presentation. Just 2 questions. Since you said her blood pressure was uncontrolled for the past 6 years, is it?
No, past 2 years it had been started to be into the higher side.
Is
And
it
they have
only
sorry?
Is it only by office BP measurements, or was sort of white coat
Yes.
hypertension
Yes.
evaluated at
Yeah,
that time?
it is only the office blood pressure monitoring, because there were no proper way for home blood pressure monitoring system. And maybe that after the cardiology referral, they don't know whether they will arrange an ambulatory blood pressure monitoring for her. But at the divisional level at that hospital, those facilities were not available for her. But maybe that after the cardiology referral, they might arrange an ambulatory blood pressure monitoring for her.
All right. Okay, thank you. Second one is, were there any stressors, depression,
Yeah,
anxiety, anything that could have contributed?
Yeah, I mentioned like she was a housewife, and they were village people, and they were sort of happy with what they have, sort of. So they did not have any major issues. The
Ah,
two children were schooling to the nearby school, and husband was a farmer. So
right.
they were. I could not identify any acute stresses going on in her life.
Oh, thanks. Just one more question. She's on amlodipine 10 BD. Is it?
Yes, yes.
Uh, is it? Do we usually give maximum 10 daily? Uh, just to clarify, is it okay?
I'm not sure. She was on 10 BD
BD.
dose.
Uh-huh.
Yes, that
I
I'm
think.
not sure. Yeah.
Uh, I think usually 10 daily amlodipine. Madam, anything on that?
Yeah, I think it's what you tell is very correct, because if you want to like increase the dosage, you have to search for another one. I mean, like adding another different category of medicine, because usually
Okay.
you can like amlodipine 10 BD is a huge dose. It's a vasodilator and cause a lot of adverse effects for her,
Okay.
right? Because of that, it's a very huge dosage. And anyway, whatever said and done, I'm very happy. Ultimately, it came off nice presentation, nice flow. I'm very happy. How much you spent time. Ultimately, I think you must be very happy. What is the end product? Like it's very important, sort of the presentation, because it's a very common every day you come across these type of patients, so you don't know what to do, and what is the way you have to look at the person. So there are like, oh, you nicely addressed each and everything. It's very nice. And I think this particular this presentation should be available for everybody. Especially, I must tell, there are, like, I think I saw there are 3 medical officers in my family medical clinic in Homagam. They are also with the all now. So I think you better, one of the registrars who at the moment attached to Homagam should give this presentation to them as well. Is Dilani or the Chandani is there, isn't it? I saw 3 people. Anyway, I will hand. I think it's important for them as well. Anyway, I think Tarindra, you can give that presentation to them as well. Nimasha, you better. It's available for you. Tarindra, are you there?
Yes, madam, I'll give them.
Right. Okay. Good. And it's very good, because not only for the registrars, just it is good. There are a lot of theory parts are there too. It's mainly each and every the long cases, keys, the hypertension part is there. These minor things. Of course, you even do not think about those things, which is very important. Though the main concern is something else. The patient must have some ongoing illnesses like hypertension, so we have to control that as well. So it's but it is very, very, very comprehensive set of slides. So because of that, you may need a lot of reading in each and every slide, and you may gather all the information. I really appreciate you included some researchers, as I mentioned to you earlier. It's very good. So there's evidence is all there. So the way you have to present is like this. You cannot just read some things. It's very important for you to look into the world and what's there, what's going on there with the new researchers and everything. So anyway, I'm very happy about you as a first year registrar. And then you ultimately came up with a very nice story and a set of slides. And I must tell you this thing for everybody. If you want to join, please join. And though if you decided that you want to join, please be with the presentation. Please don't leave the thing then and there, which is very sort of embarrassing for all the speaker. If you decided not to participate, please don't participate. I don't like it at all. Right? If you want, stay. And once also I've told, till we finish the question and answer part. Don't leave. It's very, very like, it's sort of, I mean, for a registrar or whoever, it is not the way you have to behave, right? It's very bad. I don't like it at all. I don't want to see those things hereafter, right? Okay, the others, of course, you can ask those questions, other questions.
Dr. Nimasha, thank you very much for your nice presentation. It's very informative. I want one clarification. I saw in one of your slides that insertion of IUCD is contraindicated 4 weeks before, after the postpartum. I think in some centers they practice IUCD insertion just after the delivery.
Yes, just after the delivery, I think it's possible. But then if it is delayed, then you have to wait for 4 weeks and then insert, I think.
Yeah, what we have to do is about 6 weeks. Yeah, after the 6 weeks,
right, okay.
we can reinsert it.
Okay.
I think what they are practicing just after the delivery, they insert the IUCDs.
Okay.
Only problem is there is a high expulsion rate, but anyway, it's good because they don't like to come to a second visit for IUCD insertion.
Yes, yes.
That's why.
Okay. Thank you very much.
Here, 3 registrars.
And Dr. Nimasha, what about her salt intake? Was there any change or did you inquire about that one also?
Yeah, her diet was a normal diet. So added salt were not there. So normal 3 meals, village diet. So I assumed that it was a normal intake. There were no excess salt intake. I could not identify in her story.
Yeah, okay.
If you don't have any questions, we'll wind up the session then.
Okay, madam. Thank you, Dr. Nimasha, for that nice elaborative presentation. And I think it's a very good start for the junior most batch. Such an excellent presentation. And thank you, madam, for your input and knowledge as always. So with that, we will wind up today's session. Hope to see you all again in another 2 weeks' time. Good night.
Okay, and thank you.
Thank you, madam.